Okay, now that we've done a little bit of an overview of some of the most common and highest yield upper extremity blocks and the principles and some of the generalities around ultrasound guided regional anesthesia, let's go ahead and talk about a few, again, of the high yield, most commonly performed lower extremity blocks. Again, this is not comprehensive. These are just some of the highest yield, most frequently used. And here's a quick overview of just some of the territories of some of the ones that we're going to look at. The first one, the highest yield by far, the one that has probably the best literature base, the one that's most commonly used in emergency departments across the country, is the Fascia Iliaca Compartment block. So you can see the distribution here. The next up is the popliteal or sciatic block, depending on exactly where you do the injection. And you can see the distribution of that here. And then next up is the posterior tibial nerve block, which we do at the ankle to anesthetize most of the bottom of the foot. And again, so if you were asleep, if I knocked you out, wake up for this one, because this one is the highest yield, probably the one that, if you're not already doing this, is probably one of the first ones that you might start doing as a regular part of your practice, the Fascia Iliaca Compartment block. And why? It's been widely adopted. It's been shown to be very safe. One nice thing about this is your needle's not really that close to the actual nerve or the artery. So in theory, maybe your patient can be a little less interactive, although I still think they should be awake and able to interact with you. There's a very strong literature base, and in many emergency departments, this is just a standard thing. If a patient comes in with a hip fracture, they're getting this block. It's being used in our emergency department. It's not quite a protocolized thing yet, but that may be coming down the road. So here's pretty much where the injection goes, and gives you some idea on some of the territory you're covering. So for the most part, you're able to anesthetize the femoral nerve, the obturator nerve, the lateral femoral cutaneous nerve, and somewhat of the accessory obturator nerve. And just again, reminder of the distribution of anesthesia you should expect. This is a nice, easy block. It's great for hip and femur fractures. The most common are the hip fractures that we all see every day. But don't forget to think about it if you have got a large thigh wound that you need to clean out and repair, or a large abscess maybe somewhere on the thigh. And again, because you shouldn't have your needle right up against a nerve or an artery. They don't maybe necessarily, some of these older patients who have hip fractures, sometimes maybe they have some dementia or something else. And in these patients, that's okay, because again, the risk is lower. Just a couple of key tips. Importantly, you want to make sure you stay high enough. You should be right up in the inguinal crease, just millimeters inferior to the inguinal ligament for the most part. This is a large volume block, so depending on what anesthetic you're using, you probably want to dilute it. I personally, most of the time, am using 20 mLs of 0.25% bupivacaine, and I'm diluting that with 20 mLs of sterile water or saline. So I usually have 40 mLs drawn up, and most of the time, in most adults, I inject the whole thing. But we're diluting it to, one, give us a large enough volume, but still not be at a toxic dose. And just I like to have a little algorithm for how I identify these structures and these landmarks. So what I like to do is I make sure I stay high at the inguinal crease and identify the femoral artery, and then I slide laterally and I just follow the fascia that's right over top of the iliacus muscle. This is one of the best videos I've seen on just identifying the landmarks by Dr. Mike Stone.
You're going to see is the femoral artery here, the femoral vein, which will be collapsible and may be obliterated if you've put a lot of pressure on when you start your exam. And then out laterally to that, you've got this hyperechoic triangular structure, which is the femoral nerve. Now, this is your start point, and you'll see the fascia iliaca on top. But this is really just a place to start, because the nerve's going to be just lateral to the artery, and it'll help you kind of get your bearings. So once you start, you're going to go ahead and make sure that you have these structures identified. And as we slide the transducer away from the midline and away from these vital structures, we're going to get a view that looks like this. And once you have this view, you're ready to get started.
So I'll just point out, this is the fascia iliaca here. This is our target. We're going to bring our needle in plane. We're going to get it just under that fascia, and we're going to try, with our injection, we're going to try to peel the fascia off of this iliacus muscle. And here's an example. In this case, we're going from medial to lateral. The femoral artery is over here. Our needle is coming right down through here, and you can see here's the local anesthetic being injected just under that fascia iliaca, peeling it off of that iliacus muscle. There's the needle, fascia. We want to get right underneath of it. There's the fascia. We're peeling it off of that muscle, and that's exactly how we do the injection. Another thing to note, is when you're doing this injection, you should not feel, this should inject very easily. If you're feeling resistance, then you're not in the right spot and you should adjust.